started here. Pretty much everybody's here that's going to come. I'm Dr. Slattery. I'd like to welcome you all to Washington Orthopaedic Center. Hopefully you managed to pick up a few cookies and a little bit of water there to get yourself through this long meeting that we're going to have. We're going to try to keep it brief as possible. I mean, basically the topic tonight is shoulders and shoulder pain and what we can do about it. Shoulder pain is an extremely common problem, as you all know, and probably most of you have had some of it, otherwise you wouldn't have the interest enough to be here. So as I said, I'm Scott Slattery. I'm one of the surgeons here, and I specialize in sports medicine and taking a lot of pride in providing top-notch care here and taking some time to get extra board certification and specialty training in this area. And one of the fun things I do that you can see there in the bottom, besides all the boring stuff at the top, is I'm one of the team physicians for the U.S. ski team. So a few times a year I get to travel around with some of the athletes and do some good stuff. So also with me, Jennifer, is your stand up. Oh, maybe she is stand. Yes. Jennifer is that young lady back there who's my physician's assistant. She is great. You guys will love her. She's an awesome help, and she helps around the office and sees patients for me and helps assist in the operating room. Is very good. In addition, then the next person to stand up is Andrew. Andrew Martin is an athletic trainer. He hails from the Toledo area and went to George Fox University and did his BS in athletic training there. And while I was there, managed to play on the national championship baseball team there at the time. So pretty proud of that. And he also, in addition to helping us here, he functions as the athletic trainer at Slattery College. So as we talked about, is mainly shoulder pain. And we'll start with some of the rotator cuff related causes of shoulder pain. And for most patients that come into the office that are over 40, there's usually some interface with the rotator cuff and surrounding joints that's the main problem. The younger patients, it's a little bit harder to pinpoint sometimes. It can be more often some signs of instability or simple overuse, but it's usually older patients that start to get the wear and tear of the rotator cuff that contributes to shoulder problems, just kind of like wearing a hole in an old pair of jeans as it kind of gradually thins out. And so it's a spectrum of problems. There can be impingement and bursitis, and I'll go over each of these a little bit more in detail. Acromioclavicular joint arthritis, that's that bump right up here on the top of the shoulder. Adhesive capsulitis, or what we often refer to as, or you've probably heard of this, frozen shoulder, very stiff, tight shoulder, and rotator cuff tears. And we'll just kind of go over some brief shoulder anatomy. Obviously there's the bones that make up the core of the joint. There's the ligaments that connect the bone to bone, and then there's muscles and tendons which attach to the bone and move the joint and actually create the motion that's present. So the basic bones is pretty simple. There's, three basic bones. It's your shoulder blade or your scapula, your humerus, which is the name for the upper arm bone, which has the ball part of the ball and socket, and the clavicle or the collarbone, which comes across the top right here. And how those interface are the three basic units as far as the bones are concerned for the shoulder. The ligaments are things that connect bone to bone, and those are the deep structures, the joint capsule that attaches the socket directly to the bone, the kind of the deepest layer of the joint. You can also see here, and I'll kind of try to highlight this a little bit, these corticoclavicular ligaments and coracoacromial ligaments. These are fixed ligaments running between two sections of bone that help stabilize the joint. And then there's also something called a labrum, which is a little gasket that surrounds the socket, kind of a connective tissue piece there that is part of that ligament capsule. And then the muscles and tendons, the rotator cuff and the biceps and the deltoid. Everybody always usually want to explain people what a rotator cuff is, and they call it cuff because it comes in kind of like maybe the cuff of your pants or the cuff of your jacket and surrounds that spot and attaches to it. And it's a group of 4 separate muscles and tendons, one in the front, 2 across the top, and around the back, and then one small one down here. And you can see these labeled here, the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. And the most commonly involved one in most patients if they have rotator cuff problems is this one here on the top, called the supraspinatus, right here in this area. And then the biceps, is obviously we know our biceps down here, but at the top of the biceps, as you can see through here in the front, there is a tendon that runs all the way up and goes into the joint. And it's like a rope kind of going into the joint and sawing around a corner. It can be a source of pain and disability as well. And the deltoid, of course, is the big muscle on the outside of the shoulder that everybody tries to build up with weightlifting. and that is one of the main actuators of the shoulder. So let's start with the problems, impingement and bursitis. Everybody's heard of bursitis, but I think a lot of people are unsure what it is. I mean, a bursa in general is a small, thin sac. It's made of thin tissue that's filled with just a tiny bit of fluid that helps lubricate planes of motion in your body. You have bursa all over. You've got a bursa between your skin and your bone here. There's some in your knees. And there's obviously one here in your shoulder between the rotator cuff and the overlying bone to try to help make that run smoothly as it rubs in that area. And so what the bursitis is the bottom one here, the inflammation of the lubricated sac of tissue between the rotator cuff and the acromion. And that can come about just from overuse, as it might in a younger patient, or chronic inflammation in relationship to rotator cuff problems. And the impingement part of things, when someone says you have impingement, that's a little bit of a generic diagnosis, but in general, for it to be precise, you want to have mechanical compression and wear of that rotator cuff as it rubs back and forth on the upper structures. And that's, as you lift your arm up and move your arm around, you can imagine those bumps move up and around, the tissue moves up and around. There's plenty of opportunities for rubbing and wear there in that area. The basic causes for impingement, for most people, it's some weakening and degeneration of the tendons due to aging. So the tendons just don't stabilize the shoulder down and control the motion as well as they should. A tight shoulder with loss of motion. Very commonly, people with impingement and problems with their shoulder in this area have some tightness in the back of their shoulder, so every time they lift their arm, it's almost like a yo-yo winding up a string instead of it spinning in one nice spot, and it drives that ball up into the roof overlying the socket and creates the pain. And when those tendons get weak and the shoulder gets tight, it can accelerate the process and make the wear and degeneration worse. And along with that, then, as time goes on, you can have the bursitis associated with it and bone spurs that can form over time. And those can make the problem worse by rubbing worse on the rotator cuff. Once again, the bottom bullet here, the overuse injuries, that can fit for all ages, but that's more common, once again, in younger patients that come in with a lot of overhead play, tennis players, pitchers, swimmers. Their tissues are still relatively normal, we hope, at this point, but they've just kind of overloaded them. But I'll tell you, with the way year-round sports and single, people specializing in one sport, guys pitching year-round now, I mean, more than the major league pitchers do, we're starting to see, rotator cuff tears and degeneration in 16-year-olds and 17-year-olds occasionally. So it is not always the older people. And some of the symptoms is a typical thing. Yeah, why are we talking about here? We're talking about pain. Well, there's one of the symptoms, pain, shoulder ache. It's usually worse with overhead activity. There's kind of a painful arc where as you lift your arm up, it'll start to hurt, and then it'll kind of hurt through a certain range of motion as you reach for things. And some people will complain of night pain, and that's a lot of times what brings people in the office, is they finally get tired of not being able to sleep because their shoulder hurts and they've got to do something about it. During the day, they kind of tolerate it, but boy, at night, it keeps you awake. It's not a lot of fun. And how we make this diagnosis is just through simple history. I ask questions. I ask what causes the problem, what exacerbates it, where is the pain located, and all those things we can take together and usually get a pretty good idea by the end of the history what actually the problem is. And then we add to that some specific physical examination tests. Commonly with the shoulder is a common area of the body we'll do what we call diagnostic injections because there's so many different things going on there. There's overlap with cervical spine and nerve problems. We'll occasionally inject local anesthetic into different places of the shoulder to see if the pain goes away, to try to help really localize the pain to that one area. And of course, x-rays to look for arthritis, and an MRI is necessary then to look at the soft tissues where the x-ray can really see the bone and the loss of cartilage a lot of times. And obviously the main thing to treat this is, well, stop doing what's causing the problems. Well, sometimes you can't do that. And almost everything causes a problem. Non-steroidal anti-inflammatory drugs like ibuprofen and Aleve, typically gone over the counter, are commonly prescribed, and they can help with the pain and also can address some of the inflammatory processes that are there. Along with that diagnostic injection, a lot of times we'll put a little measure of cortisone in there for good measure if we're pretty sure it's bursitis or inflammatory problem, and that can sometimes dramatically treat it. It doesn't work in everybody, but I've had many patients who, after a cortisone injection, they went away, and I saw them several years later for something else that says, oh yeah, it's been fine ever since that shot. Sometimes it can work really well. And one of the things that we're going to emphasize tonight, and Ryan Winning, one of our physical therapists, is here to talk about that a little bit more, is exercise to restore the normal flexibility and strength of the shoulder. Usually, by the time somebody has come in with shoulder pain, there is some mismatches in flexibility, like we talked about, some stiffness and some weakness. And sometimes it's hard to know. It's the old chicken and egg thing. Did somebody get tight and weak first and then cause some of the extra wear? Or is this a response to the pain? And it could be either. It can create a vicious, self-reinforcing cycle of pain. So if we notice some deficits in strength and some imbalance in the muscles and the way the shoulder moves, stretching exercises and strengthening and functional exercises to try to improve the coordination of the shoulder can be really crucial to dealing with this. And of course, if all else fails, we will sometimes proceed with surgery. For straight impingement syndrome, I really try to treat this as conservatively as possible and don't push towards surgical treatment unless somebody's really not doing well and they failed therapy for a while. I consider it typically a non-surgical problem, but as you can see here, if you have a carefully selected patient who's had some temporary response to injections, they failed other things, to get in there with the scope through just 2 or 3 little tiny incisions in the shoulder. We can look inside of the camera, make sure there's nothing else going on. And if all it is quote, impingement, we can remove that bursa. We can smooth off some of the bone spurs and try to decrease that mechanical compression and wear in there. And in those patients where if you choose them right, there's at least a 90% success rate. Patients feel better and they're happy they had it done. The recovery rate of a basic arthroscopy for impingement is fairly quick. There's no real restrictions in motion. We're not trying to protect or repair. People can start moving and using their arms for light activities fairly quickly. Acromioclavicular joint arthritis. The acromion is that bony process here. The clavicle is that big knob that some of you may have right on top of your shoulder right here where the collarbone comes into your shoulder. And that area commonly becomes arthritic in almost everyone. If I were to MRI anybody over 35 practically, or some x-rays, almost everybody has some degree of AC joint arthrosis. Fortunately, it's not always symptomatic. But it can cause pain and can be a source for pain. It can contribute to impingement. You can imagine that if that bone there, made a big bone spur off the bottom as it got really arthritic, you could rub in the rotator cuff underneath it. So it can contribute to that. And it can just be painful in and of itself. And we evaluate that with physical examination and x-rays. And sometimes it can be related to old injuries, like an old football injury where you separated your shoulder joint. Usually, if that's the only thing going on, a lot of times AC joint problems are present in relation and going along with rotator cuff and other problems. But there's people that have just direct AC joint problems. And they have a tendency, if that's all they've got going on, they have a tendency to be a little younger. They'll usually point, doc, it hurts right here. And they can usually really pinpoint it. And there's tenderness there with certain movements, like moving the arm across your body, which compresses the joint. You can reproduce that. And then pretty much almost everybody gets at least one diagnostic injection to the joint to help see if the pain goes away temporarily at least. And that helps confirm that. In fact, just in the last several months, the government makes all sorts of choices here. They don't allow us to choose as much as we used to anymore. They pretty much have mandated that if they're going to cover anybody for a surgery on this, they have to have had at least one injection in the joint. Don't even if it's clinically obvious, don't really give us the choice. So there can be clicking and snapping associated with it as well. Same things here: rest, anti-inflammatories, cortisone injections, and surgery. And for surgery is also relatively straightforward. Fortunately, that actual bony connection between the two areas is not super crucial. The ligaments that stabilize the shoulder are attached elsewhere, so I can once again go in with a scope through a couple small little holes and use a little motorized burr and take off about 5 to 10 millimeters of the end of the bone so it doesn't rub together anymore. And in somebody, once again, who has all those diagnostic things that go along with that, it pretty much fixes them in a great percentage rate. Adhesive capsulitis. That's the frozen shoulder. Frozen shoulder of varying degrees is probably more common than we give it credit for. A lot of people come in with partially stiff shoulders, and it may not be a full-blown case of frozen shoulder, but it's certainly partially there and contributing to their problems. The classic case of frozen shoulder is much more common in women than in men. I don't see it in men very often. Usually the men that have it have some other issues going on, like diabetes. And it'll be just one, there's a lot of times there's no trauma, nothing that starts it. Just notice all of a sudden one day their shoulder starts to hurt and gradually starts to get stiff and it becomes painful. And it's a very painful condition. It goes through several phases of natural history. There's the inflammatory phase at the beginning where it pretty much hurts all the time and the range of motion is going away. And that lasts a variable length of time, maybe about 3 months. Then it kind of goes into a chronic phase where it doesn't hurt all the time, but the shoulder's still really stiff, and you try to go beyond the range it wants to go, it won't let you, and it hurts bad. There's a lot of problems with the shoulder that cause loss of elevation because of pain. But if somebody really loses a lot of motion, can't even rotate their arm at their side, you need to start to become suspicious a little bit that that could be, at least a portion of it could be a frozen shoulder. Because most things shouldn't hurt that much in just a simple range at the side. We can use physical therapy as a mainstay of treatment. Injection can sometimes help, especially early on. It's better, if you're going to do an injection, you need to do it earlier during that inflammatory phase, and you can kind of speed the process up. Adhesive capsulitis is a diagnosis that has been said requires a lot of patience on the part of the patient and the physician. Historically, if you give it enough time, it in general will get better on its own. But the course can be quite prolonged and be a year or 2 years sometimes before the pain and before the motion and function and things like that return. And it doesn't happen in everybody, but most patients, if they don't want anything else done, will get better. I do on some patients with very stiff shoulders that just are very limited, and everything else has been tried, and they can't just go for that 2-year period to see what happens. We can do surgical treatment, which has a pretty good success rate. It's called a capsule release, and you usually need to wait at least 3 to 6 months from the start of the problem. You don't want to do it during that early inflammatory phase, or it may just stiffen up again. So you got to wait till it kind of gets in that chronic stiff zone, and then you go in with a scope here, and you can kind of see a picture here with a little electric cutting knife, where we cut that tight, thick band of capsule there and release the shoulder and get it fully moving underneath at the end of the procedure. And patients are that's a fairly successful procedure if it comes to that. And then the rotator cuff tear is one of the more common problems we see, some variation of it. Once again, it's due to just, in general, age-related degeneration. But there can be traumas along the way, of course. Once again, the wearing a hole in your jeans analogy. The denim gets old, it gets thinner, but all of a sudden you fall on it. Well, you may put a little bit of a hole in it, and then you kind of gradually enlarge it and wear it out more and more over time. The rotator cuff has a poor blood supply, especially that top tendon, and so it's under a lot of load, and it just doesn't have a lot of capability of healing itself. And so it just gradually wears out. Once again, things are overuse, time, trauma. And a lot of tears are asymptomatic, actually. I mean, if I were to, you can see here, 51%. If I were to take 51% of 80-year-olds that had no pain at all in their shoulder and MRI their shoulder, 51% of them would have some tearing of the rotator cuff, if not a small tear, a partial tear, or all the way through. And that's kind of one of the things you have to be careful if you just sort of, get an MRI in everybody, you'll find all kinds of things that, may not be necessarily the cause of the problem. Symptoms, again, are often pain. Night pain is more prominent with the rotator cuffs even than the bursitis. Very common complaint. Sometimes can be fairly significant weakness and decreased motion. And especially if somebody's started this off by a fall, those are the guys that will really notice a sudden change from pretty good function to really poor function. Whereas the ones that kind of creep up on you, it's not as bad. And they can have secondary stiffness and a frozen shoulder with this as well. History, once again, the standard things: history, physical examination, x-ray, and a lot of times I can get a pretty good idea by the end of that what's going on. But if there's any question or to confirm the diagnosis or help plan for any surgery, we get an MRI, which looks at the soft tissue again and can see what's going on there. And you can see here on the MRI, this is a kind of an artist-enhanced version of it here, but there's supposed to be, this tendon right there is supposed to go all the way out here to the bone. And it doesn't. So that's a pretty good sized tear, and you can kind of see the artist's rendition of that right here. And that's the kind of thing we look for on the MRI. It doesn't have to be torn all the way through. Partial thickness tears are common and can be very symptomatic. We try to treat these non-surgically if possible, but if they're more torn on the top side where you're getting more rub, or if the thickness starts to get more and more, the more the thickness is, the more symptomatic they are. They sometimes will need surgical treatment, even if it's not torn all the way through. But we do some of the same things we do for impingement as we do for partial thickness rotator cuff tears. Injections and physical therapy to increase the flexibility and strength of the shoulder. If that doesn't work, you can get in there with a scope and treat them the same way. If it's just a little bit of tearing, sometimes all you got to do is clean up the tear and try to stimulate a little bleeding to get it to heal a little bit, and we can get away with that. But as you start to get more and more the thickness of the tendon, it becomes more important to actually just go ahead and repair it, even if it's not torn all the way through. And the techniques vary depending on the type and tear pattern. And I was just at the annual sports medicine meeting this year for the American Society. And this year they had it up in Seattle, which was nice, so I didn't have to drive very far. And the trend is toward getting a little bit more aggressive with repairing them more often. And starting to look at maybe 25% thickness tears and things like that. We might be worth repairing rather than just 50%. As patients seem to be doing better with this. Full thickness tear basically means the tendon's torn off the bone and there's a hole all the way through. If they're complete tears, they're not going to heal. Patients ask me that all the time. Will this tendon heal on its own? Well, the tendon tears, if they're not acute and they're really torn off the bone, they don't heal. The hole always stays there. Now, that doesn't necessarily mean they have to always hurt. They can stop hurting, but the tendon is not going to heal back to where it belongs. So there's a difference between obviously it healing and you healing in another way so you feel good even though it's still torn. For most of the time, once there's a small tear there, and if you have ongoing symptoms, unless there's some other reason otherwise, surgical repair is really recommended. I mean, once again, at the same meeting I was at, they looked at a long series trying to really nail down the differences between operative and non-operative treatment. They randomized people to non-operative treatment, to operative treatment, and the non-operative treatment patients, got just a little bit better over time. They did improve a little bit, but if you looked at the curve of the surgical ones, they usually started out worse and rapidly got better and ended up being significantly better at the end than the ones that were treated non-operatively, even though there was improvement in them. So, and the earlier you get to it, the smaller the tear, usually it's easier to fix and the better the results. So if you're symptomatic from it, you've got a torn tendon, and you feel like you can do it and there's no other reason otherwise, it probably should be repaired because I think in the long run it's going to be better for your shoulder. But, once again, there are people that cope fairly well with rotator cuff tears, and if it's not a good time in your life for it right now, you got too many things going on, or just for whatever reason, it's not absolutely mandatory, and non-operative treatment can be partially successful and improve people's function. So especially in the older chronic tears. And once again, the same thing with the impingement. Rotator cuff repairs now can be done arthroscopically, through little small incisions. I don't think, going to these meetings, there's really not very many shoulder surgeons in the country now that are making large incisions to fix rotator cuffs. It can be, it's almost kind of like if you can't fix it through the scope, it's probably not a fixable tear, and some of them aren't. But not everybody does it that way. There are definitely some advantages to it. Less scarring and muscle injury. The recovery is a little faster as far as the pain level. There's usually less problems with stiffness in the shoulder, but you still have to protect that repair just like you would do it when you're open. It doesn't speed up the healing of the tendon. It just makes it less painful, less invasive, and less complications. But the actual tendon healing rate takes about the same length of time. It's still trying to get that tendon to heal. And at the same time, we can better treat all the associated problems. When I'm in there with the scope, I can look into every little nook and cranny that you can't see sometimes, even through an open incision, and fix all kinds of stuff that I can have problems with. So obviously, I'm very biased in this, but I think the nation supports this. That if you're going to have a shoulder surgery, and and it's a basic rotator cuff repair, not some sort of an unusual thing, and your doctor wants to make a large incision on you, it's probably not necessary. This is kind of an example of what we do with the arthroscopic rotator cuff repairs. You can kind of see this complex sort of rat's nest of sutures there. There's anchors that go into the bone. Those different sutures get woven through the tendon in various patterns. And then the right side is basically pulling that tendon down, anchoring it down to bone. And now the hard part, you guys letting it heal and protecting that tendon while that healing process takes place. We've just attached it to the bone. Now the tricky part that we really haven't solved, the biology. You know, giving it the time to actually heal back where it belongs. All right, so I guess probably with this, I'm going to change topics just a little bit. This might be a good time to take some brief questions on about what I just talked about, the rotator cuff and things like that. I know I kind of went through it fairly quickly, but hopefully it kind of gets a feel for what's going on. Any questions? We can answer more. So,
how do you get a balance between, you say don't overwork a joint that's bothering you, but don't you also have to have muscle tone, and how do you get a balance there?
Well, that goes back to the three bears. You know, the porridge, you know, not too hot, not too cold, just right. And for everybody, that's a little bit of a different thing. I'm not trying to, you know, blow the question off, but you're absolutely right. It is like if you just protect it and you baby it, that's going to get worse. You're going to lose muscle tone, you're going to lose flexibility, you're going to get stiff. But then after you just have to kind of listen to your body, and you know, especially if once the diagnosis has been made and you feel like, you know, you're in one of these categories that we're trying to treat conservatively, it's impingement, we don't think it's a full rotator cuff tear, you know, and you know what tendon it is, we can describe to you what kind of motions might be the most likely to aggravate it, then you just kind of listen to your body. And you know, if there's a certain motion like starting a lawnmower, you know, that doesn't want to start, and that's pretty hard on your shoulder, you may want to get an electric starter. I mean, I'm just as an example. So you have to kind of listen to your body a little bit. We want some strengthening work to take place. If there's actually a little tear in the rotator cuff, there's probably not much of a benefit of actually trying to strengthen and pull on the muscle that's the tendon's actually torn. But if you can somehow isolate some of the surrounding muscles that are still okay, you can sometimes create some balance around the shoulder to compensate for that. So there's not an easy answer to that. It's just, but you're absolutely right. You don't want to move it too little. You need to use it. You need to keep your flexibility. But if you find there's certain motions or activities that stress that tendon in that area that are causing problems, if you can push your arm through that range of motion gently, just to keep the motion in that direction, but not do anything heavy or violent through that motion, that will usually do the trick. Does that make sense? Any questions about all that? Sure.
What about NACEs? Which ones are best for what?
There's really not a best or better one. Everybody seems to respond to them a little differently. Obviously, the two main over-the-counter ones that you can get are the ibuprofen and the naproxen, or the naproxen, which is Aleve. There's some indication that as far as if you have other risk factors like cardiovascular risk factors, non-steroidal anti-inflammatory medications, if taken chronically, have been shown to increase some people's risk of coronary artery problems if they've got some of those already, some other risks. Aleve or the naproxen seems to be the least problematic of most of the NSAIDs in that regard. It's also a little easier to take. You only have to take it twice a day because the way the pharmacology of it works. Instead of the ibuprofen, it's typically 3 times a day for a normal dose. But you basically, but if for whatever reason the full strength Aleve doesn't work, but you find ibuprofen does, then that's what you want to use. And as with anything else, since the over-the-counter, the prescription strength of ibuprofen is 800 milligrams 3 times a day. But the normal over-the-counter pills are 200 milligram pills. So with that, it actually gives you the opportunity as a patient to kind of call it titrated in chemistry to the least amount of drug it takes to be work effective for you. Start small, work big, or start big and work small, whatever works for you to try to decide how little you have to take in order to have some benefit. Now we have prescription ones also there's a whole list of prescription ones, and they all work a little differently, and some may be more effective. So if the over-the-counter ones aren't working, we can try the prescription ones. But they all have about the same mechanism of action, and there's not one that's more superior to another. There's a couple that have been designed out there, such as Celebrex, to be less irritating to your stomach if you have stomach problems when you take it. So there's some of those type effects, but they're all sort of the same. You just have to see which works best for you. Yes, sir?
I think you pretty well answered my question on the previous answer. That's what we're working on now is my rotation. I do have a slight tear in my rotator. But we're working on trying to get my arm to go out, which has been difficult.
Yeah. And if your arm is really that stiff at your side like that, you probably have, like what I was talking about, a little bit of stiffness and frozen shoulder along with the rotator cuff problem, a combined problem. That makes it a little trickier, you know, sometimes to manage. And as with anything else, I'll talk about this with arthritis, you know, a stiff arthritic shoulder or a stiff shoulder with a rotator cuff problem is always way more painful than one that has that same problem and still hasn't been able to maintain the motion. So, you know, I guess the word to the wise would be, as far as the activities, I would recommend everybody, even if they got shoulder problems, it's not going to harm your rotator cuff to gently push your shoulder, even if it hurts a little bit, through a full range of motion every day, all the way behind you, all the way above, and a little bit of discomfort, probably if you're just a little, you know, pushing it a little bit, is not going to shred up your shoulder. I mean, if it's already that bad, it's torn anyway. So just some gentle stretching, I'm sure therapists would probably agree with that.
If you've had rotator cuff surgery, can you tear it again?
Yes. It's still not a normal tendon. And I guess what I'd like to think is it sort of hopefully takes the clock on your rotator cuff and resets it, maybe 10, 20 years. I like the jeans example. You take a pair of jeans, you put some stitches in it, put a patch on it. Hey, it's great. I don't have a hole in there anymore. It's comfortable now. There's no breeze blowing, through my pants. But sure enough, you can wear out that again too, if you give it enough time and enough wear. So yes, it can be. You can have a re-tear, and whether it's a re-tear or it didn't heal in the first place is always a fine dividing line that you're not sure. I mean, probably, like I said, the biology of rotator cuff repairs is the biggest thing, and probably some failure to heal in some way is probably the most common complication of rotator cuff. We've gotten very good at other associated things and with minimally invasive approaches, but we still haven't, guaranteed that every single tear that you have is going to heal. Every tear is different.
Well, I had surgery 12 years ago, but now my right shoulder is painful that I can hardly sleep on it. But I don't know if it's that or if it's just overuse.
Yeah, it could be a re-tear, or like you said, it just could be some of this, weakness and inflammation related to overuse or impingement. But 12 years ago, it would not be impossible to think that you may have a new tear.
My shoulder is 6 years after seeing you.
Yes?
And it looks like a baseball. If you took off the leather, it looks like that. That's how busy you were stitching it up.
Yes.
and now it's bad again. So 6 years, isn't that quite soon?
Once again, it all depends on the tear pattern. I mean, if that's why I said the small tears usually heal very reliably and odd times don't go on to re-tear. If the tear was larger to begin with, there's poor blood supply, there's a degeneration that can take place, it can start to fail a little bit earlier. So, the tear patterns are quite different. I mean, there are some tears that are so big and so retracted, they're just not repairable. I mean, I'd say the majority are repairable to some degree, but there are some that are just not repairable tears. They're that large. And so it depends on the character of the tear. Yeah, I'd like to think that every single shoulder I operated on would last, until I was not working anymore. But it's, unfortunately, that's not always the case. People are usually happy with how things went, and then it can start to flare up again. But it doesn't always mean there's a re-tear. That's not always the case. But if it's bothering you enough, it's worth rechecking. And there are ways we can examine it again to see what the situation is and treat it.
Coming back to the NSAIDs, is that just to relieve the pain, or does that contribute anything to the healing, and how long would you have to take them?
It contributes, probably the primary thing is pain, but they are anti-inflammatory medications. So if there was an inflammatory process, such as the bursitis, the adhesive capsulitis, the frozen shoulder, all those things are inflammatory processes. You look in there with a scope, or you get an MRI, and you can see just beet red tissue, just like you got a bug bite. The same thing for the, if you look at an arthritic surface or whatever, there's that inflammation there, and the non-steroidal anti-inflammatory drugs can treat that and help that. Obviously, they're not super powerful. They're not going to completely eradicate it all the time, but if taken kind of on a regular basis, they can help treat that. Obviously, the stronger anti-inflammatory medications are not the non-steroidal anti-inflammatory drugs, but the steroids. You can take prednisone, and I will sometimes use a real short course of cortisone, oral cortisone, to really attack a really strong inflammatory process that I see. I don't like to use non-steroidal anti-inflammatory drugs after rotator cuff repairs in the first 6 weeks. For the same reason that there's actually, to get a tendon to heal, there has to be an anti-inflammatory process. And there's some laboratory data in some animals that seems to indicate that it may affect the healing of a rotator cuff repair if I use ibuprofen as a pain reliever after surgery. And even though it may not make all the difference in the world, in these situations, when the tendon is potentially so tenuous, I like to take every advantage I can get. Does that answer your question?
Yeah, thanks.
Yes, I have a question. I had, excuse me, physical therapy in May after they had the MRI and they found the tear. And 4 physical therapy treatments, I noticed great improvement. So I have the exercises I can do at home. And when I don't do them, I really pay for it very quickly. My question, will I just plan on doing the exercises the rest of my life for that tear?
Sounds like a good plan.
That's what it is.
I mean,
As long
you
as
know,
it's-
I tell patients all the time that you know, when I send them to see the physical therapist or I give them exercise in the office, that you need to view physical therapy to a large degree as education. You know, they'll get you on the road to potentially curing your problems, but a lot of problems have a tendency to be chronic, and you have to view physical therapy as education of what works for me, what exercises help, and then just like you go for a walk every day to keep your heart in shape, you need to do shoulder exercises every day to keep your shoulder in shape if you find that they work, and it's just maintenance therapy the rest of your life. And obviously if you get tired of that, or if you really start to get more weakness, then with the full rotator cuff tears, that's when we start, you know, sharpening up the knives and talking to people if we need to. All right, well, let's just go on and try to cover a little bit about arthritis here briefly, and then I'll let Ryan get to his part here. We go forward here. Once again, you know, this is kind of just a brief discussion of just joints here. The hip and joints are similar to a ball and socket. The hip joint is a deep ball and socket, it's very stable, but the shoulder has incredibly wide range of motion. The reason of that is because it's like a big ball in a little tiny socket. And that's where the young people have problems, is typically in instability, sports, dislocations, shoulder pops out of place. You got this big ball sitting on a little socket, and it relies on the soft tissue attachments to keep it in place, and not the bony constraints like the hip does. The ball joint doesn't actually rotate. Specifically, it kind of rotates around, and arthritis is kind of like corrosion sort of setting in. It's kind of a crude example. You know, and there's a drawing we call a healthy shoulder. Everything around the joint itself up in this area is very nice and smooth. The muscles and tendons are all healthy and protect everything. And then when you get into an arthritic joint, arthritis is the degeneration of the articular cartilage. Everybody's probably popped open a joint of a chicken, or if you're a hunter, you've seen inside of joints or whatever. There's that white glistening coat over the end of the bone in the joints, just kind of like the layer of coconut on the inside of a shell, and that's the cartilage. And you can cut down through that. It's very soft, straight down to bone, and peel it off with a peeler, and it's very friable tissue. And what arthritis is when that tissue gradually wears away over time, or sometimes it can be traumatically injured and taken care of. And as that starts to get very severe, pretty much you can imagine you can get bone rubbing on bone as the cartilage is completely gone. And the body adapts to that process and tries to take care of that process by making these bone spurs and other things like that, which then can help cause the friction and the pain in the area. So you can see a side here where we've got pictures of the bone, and there's kind of an artist's rendition of some worn cartilage in the joint. I mean, it's the #1 cause of the joint problems in the country, for sure. Except maybe the rotator cuff may sneak up on that, but we've got so many joints that far outnumbers that. 43 million people is one recent number. 1 million new patients develop arthritis each year. 1 in 6 people, 1 in 3 families, 50% of people over 65 have arthritis. And even younger people, they have a lower risk. You still see it. And unfortunately, I'm seeing younger and younger people all the time come in with arthritis. I've got 35 and 40-year-olds that have knees that look like they should be 75. Some of those are due to trauma in the past from sports, and unfortunately a lot of them are due to the person's size. They wear out their joints a little faster when they're heavy. And we're seeing a little more heaviness than we used to. Patients who suffer from arthritis come all shapes and sizes, of course. It's not just heavy people that get arthritis. Anybody can get it. And even children, if they have some deformities of their joint when they're born, can develop arthritis at a very early age. And, you know, people talk about the pain, but sometimes it's not so much just the pain. A lot of people can deal with pain, but once again, if it's pain that ruins their sleep, or pain that ruins their ability to get out and take care of the cows, that affects their ability to play golf and do some of the fun things that they need to do or have to do for work, that losing the mobility and the independence is sometimes just like the worst part of the whole deal. And as it says here, you do see depression with this. People come in and they've been dealing with these problems on a chronic basis, and it can be wearing on you emotionally as well as physically. And at some point, people show up and seek relief. We've got a lot of arthritis treatment options. Once again, there's some of the basic ones we talked about for the rotator cuff. Direct heat, to loosen up, to heat up that. People ask ice or heat. There's charts out there that can kind of give you an idea, but just in general, if you've got an acute injury with trauma, swelling, pain, or something's really flared up, ice is pretty good. That's usually the best scenario for ice. But if it's just kind of a chronic deep ache, or you wake up in the morning and this joint's just stiff, or it's cold and you kind of have a hard time getting moving, well, you wouldn't go put ice on your car motor if you're trying to warm it up. You put a little heat on that thing, get the fluid moving, and get those muscles loosened up, and a lot of times it will feel better. Physical therapists, once again, a stiff arthritic joint is always more painful than a loose arthritic joint. And the whole what comes first, there are some people that hypothesize that sometimes an illness or a weakness that illness or some other problem that creates some weakness may precipitate the pain. You see all the time people that come into the office and say, doc, my knee's been hurting me for about 2 months now. Have you ever had any problems before? No. You get an x-ray and they've got a horrible arthritis. That just didn't happen 2 months ago. It's been going on forever. And then why did it all of a sudden start to hurt? And there's no easy answer for that sometimes, but sometimes it's finally reached the point where the joint's gotten stiff enough or weak enough that the joint's not being supported and protected, and then the arthritis becomes painful. And the physical therapists help us maintain that joint mobility and strength to try to optimize the function. And there's a fair number of people who with just a little bit of extra work in that regard can at least get the pain from their arthritis down to a dull roar enough they don't feel like they need anything else done. Medications, the non-steroidals, the Tylenol medications for pain. And also you obviously make sure you're starting to take these things chronically, even if you're getting them over the counter. Just because you can buy them in the store doesn't mean they're not going to cause any side effects. And non-steroidal anti-inflammatory medications can cause side effects. They can cause gastric bleeding. They can cause stomach and liver problems and kidney problems. And so it's not something you want to take tons of on a chronic basis without having somebody check out your rest of how your body's working. Then we start talking about joint replacements. And obviously the most common joints that most people here know about is hips and knees. But shoulder replacement surgery is probably becoming the fastest growing segment of the joint replacement population. We're doing more and more of them, seeing more and more arthritic joints. And partially because I think they're becoming more successful. Someone who comes in with a very stiff, arthritic, painful shoulder, and we replace the shoulder, is usually pretty happy. And you can kind of see what we've done here. There's a picture here of you take that worn out ball and you make a nice smooth round ball, and you take that worn out socket and you make a nice smooth socket. And that's a primary replacement where we're just resurfacing those worn out joints. If you've got severe arthritis, if you've tried everything else and the pain is disabling and you can undergo surgery, joint replacement is an option for you. And when we come in there, we go through the same thing we always do. We discuss, your situation, what your goals are, what your plans are. I always tell patients we don't treat x-rays, we treat patients. If someone walks in the door with an arthritic shoulder, I'm not just like saying, oh, you need a joint replacement and walk out the door and leave. There's a discussion that needs to take place about what your expectations are and And so there's a lot of times we can get by and do things without going to that extra degree of replacing the joint, which is, although successful, is an invasive procedure with potential complications. And as I talked about, the primary shoulder replacement is where we're basically trying to keep the normal anatomy as much as possible. To do a primary shoulder replacement requires a pretty good functioning rotator cuff. Fortunately, most people actually, they get severe arthritis, their rotator cuffs stay together. It seems to be the people that don't get arthritis that wear out their rotator cuffs more. It's one or the other. But that's obviously good for us because it allows us to go in there and just put a new ball and socket in there in most people and relieve the pain and improve the motion. And we use instruments that allow us to make different sizes and match them to the size of the patients and really kind of get an anatomic fit to recreate what would be their normal anatomy. And you can kind of see an x-ray of what we've got here, worn out. This is the bone-on-bone arthritis. Let me see if I can find my pointer right here. There is no joint space left here. There's a big bony spur down here, and that's a painful shoulder. And you get in here and you put a new smooth metal ball and a nice piece of smooth plastic for it to rub on, and it works a lot smoother. And once again, we talk about realistic expectations. Most patients can expect to experience a dramatic decrease in the pain in their joint. They're very happy about that. Function is always a little tougher. Being able to hit a tennis ball again may be out of your reach. Most people's shoulder motion improves, but a lot of times it doesn't come back completely to normal. There's still a little residual stiffness sometimes. And so the goal here is to take somebody who can hardly get their hand up to comb their hair or sleep at night and basically have them be able to reach for a dish on the shelf, pull a milk carton out of the fridge with very little pain in the joint. Not necessarily a perfectly normal shoulder. Then this reverse shoulder arthroplasty. A lot of people haven't heard of this. This isn't done as commonly. There's indications aren't as common. There's not a lot of surgeons that do this. But this is a tool that we have here at Washington Orthopaedics and at Providence Hospital, where this can solve problems which were kind of previously unsolvable. Somebody who has a large rotator cuff tear that's been there for a long time will oftentimes go on to wear their shoulder out. The rotator cuff tear is big, it's unrepairable, and then they get arthritis as a secondary thing. And that's almost has been an unsolvable problem in some ways until this new thing. And you can see the difference here. They call it a reverse because the ball is on the socket side and the socket's on the other side. And it's basically a mechanical geometry change that now allows you to lift and move your arm even though you don't have a functioning rotator cuff. And in very debilitated patients with this, it can be a life-changing operation. It's typically, most of my patients are in the older age group that I do this to. It's 70 years or 75 years or older most of the time, and so it's not just a young person operation, it's actually an older person operation. And that's the basic components there that we use. And we basically, once again, fit the anatomy to the patient, fit the parts of the patient. And you see kind of the close-up of the metal ball there for the reverse, and kind of a picture. This is somebody who had a primary shoulder replacement. This isn't one of my patients, this is somebody else's patient, but where they were in a car accident, tore up the rotator cuff, now their primary shoulder wasn't working anymore, and it was converted to one of these types here. Well, thank you very much. Before I go on with Ryan, any questions about the arthritis side of things, the shoulder replacements?
There's a common thought out there that glucosamine helps prevent arthritis. What's your thought on that?
There's been no scientific proof that we can tell from the best science studies we have that glucosamine does anything to prevent arthritis. There are some studies that show it may decrease the pain related to arthritis, but even those are not convincing enough for us to actually recommend it to patients. And when I say it that way, that's kind of a nuance. It doesn't necessarily mean it doesn't work or couldn't work for you. It's just that before I actually recommend it and tell you to go out and spend the expensive bucks that those big bottles of glucosamine cost and take it on a regular basis for every day for 20 years, I'd like to say, I want people to say, this will really work. You should go do this. But it's not to that level. And so I will tell patients in it, I said, it's not going to stop your arthritis, but it can decrease the pain and make you more functional. And I've seen some patients who say it helps, and other patients who say it doesn't help. So it's kind of up to you to try it and see, but the evidence is minimal.
What about tendonitis? How does that differ from arthritis?
Tendonitis, most of the things that we've called tendonitis in the past probably aren't tendonitis. We get really picky about the verbiage there. We used to use tendonitis, is still used in the medical literature a lot, but that technically means actual inflammation of the tendon. And you can get that, like calcific tendonitis, for instance, is one example thing that I didn't talk about, where it's almost kind of like gout, where these calcium crystals get deposited in your tendon and can create a real strong inflammatory response, which is really painful. So it's actual inflammation of the tendon itself. But most people's rotator cuffs that wear out, it's really probably more what we refer to as tendinopathy, not actually an inflammatory process. You put these pieces of tendon under a microscope, a lot of times there's not of actual inflammation in the tendon itself. There can be in the surrounding bursa and other tissues, but in the tendon itself, not always a lot. And it's just more degeneration of the material that's there. So there are some true cases of tendonitis, but most of what we're dealing with is probably not inflammation of the tendon. It's maybe some inflammation of the surrounding tissues from mechanical wear and other issues, but the tendon itself is wearing out. It's degenerated. Does that make sense?
How's it treated?
Well, once the tendon is starting to degenerate, how we treat it is the same way we treat this stuff here. That's what goes, the degeneration is a spectrum. It starts from minimal degeneration to these partial thickness tears to full thickness tears. It's like, once again, wearing a hole in your pants. And in the earlier stages, if we can catch it at an earlier stage and we can find some underlying problems which may be contributing to that, such as poor shoulder flexibility or strength imbalances and other things like that, that's where physical therapy is really the most important. Now there's a lot of research being done to try to figure out how to treat tendinopathy. If you Google platelet-rich plasma or PRP, you'll get a million hits in there on different people that are doing these things. Basically, it's injecting growth factors and all kinds of things like that into the tendon to try to get that degenerated tendon to turn back into a normal tendon. And so far, even though there's a lot of hope that one of these biological solutions will come about, as of right now, we haven't discovered a good way to reverse those natural degenerative changes in the tendon that occur with age and wear. There's one process that I may be working on here in the next year or so. That's a new device. It's kind of on the, it hasn't been brought out to sale. They're just kind of introducing it to a few surgeons to try, and it's okay. It's been okayed by the FDA to try in patients, which is basically almost kind of like a little bit of a patch, where there's some actual bovine or cow collagen that you sew into place over defects and portions of the tear, and it seems like in laboratory studies so far it may actually be growing as part of the tendon and thickening the tendon back up. So there's a lot of work being done in that direction, but it's not there yet. Any other arthritis questions?
You had mentioned that younger folks, you're seeing arthritis in younger folks. Any tips on how to try to prevent that from getting worse?
Yeah, I mean, to prevent it from even starting in the first place, once again, it's finding the, everybody can't be the boy in the bubble. You can't just go, life has to be lived and experienced and sports enjoyed and other things take place. But probably the most common cause for early arthritis in most young patients is some sort of trauma. Unfortunately, anterior cruciate ligament tears in the knee is an example, or recurrent shoulder dislocations, multiple recurrent shoulder dislocations in the shoulder are becoming more and more prevalent, especially the ACLs in the knee. We'll go to the knee area there. And that just is based on a lot of things, and sometimes it's just the sheer volume that they're playing. I mean, people, back when you and I were in high school, I mean, people didn't play year-round and won soccer year-round. If you play soccer year-round, it's a very high-demand sport. You're going to subject yourself just like somebody who drives on the freeway every day of their life as a commuter for 100 miles. Well, they're much more likely to have a car accident than somebody who just has to commute down the road. It's just the sheer volume of exposure, I think, is a lot of it. And that trauma, once that trauma occurs to a joint, it damages the cartilage, and a lot of times that starts that cascade of degeneration that it's hard to reverse. So being careful with overuse, being as careful as you can with good conditioning, and appropriate protective equipment and play gear and other things like that. And then just, as far as the conditioning, once again, is maintaining the flexibility and the strength so you decrease as much as possible your chances of getting an injury.
Can you get arthritis in your feet?
Absolutely. I mean, every joint in your body has cartilage in it, and so those can wear out in every area. And so, foot arthritis is, that's why arthritis is the most common problem, affecting the body here, because you've got 100 joints in your body. If you count all the little toe joints and the foot joints and the, the jaw and the thumbs and hands and wrist and everywhere.
You end up having surgery for that, or?
I mean, same sort of situation. I mean, if it's symptomatic enough and none of the other things that you're working, such as protection or medication or things can help, surgery, depending on what they are, can be helpful. And there's a couple different types. I mean, I'm not Dr. Dugella, who's our foot and ankle specialist, who actually just joined our group in the last month here. That's his area of expertise, but it all basically comes down to either fusing the joints so it doesn't move anymore. If it's not super crucial, they have a lot of bending to it, and that can fix the problem, to resecting the joint, or sometimes even little mini joint replacements in there. But most of the time, with the smaller joints in the hand and the foot, we try to treat them as non-operatively as possible. All right, with that, you ready, Ryan?
I'm ready.
All right.
Well, thanks, Dr. Slattery. That was a lot of information, and what's nice is that I'll just kind of make this a little bit briefer, just kind of give you an overview of what physical therapy is a little bit about, especially when we see some shoulders. And anyways, my name is Ryan Winning. I'm a physical therapist and a supervisor right next door here for Providence. I have been working for Providence for about 11 years. I've been supervising one of the offices at least for the last 7 years, and I've been working really close with all the orthopedic doctors here for many years now, so we have a good relationship, we have good communication, we usually know exactly what they're after when they refer someone to us, and I think we are able to communicate and always kind of give them updates on how their patients are doing. Quickly, a show of hands, how many have had physical therapy for your shoulders? You're going to need physical therapy, and you're definitely going to need physical therapy. You're going to need to see Dr. Slattery. Sorry. No, but in seriousness, what is physical therapy? Some people, or some of you have not even tried it. Maybe you've had it for your knee or foot. So a little bit of this is familiar. I mean, we're here basically to try to help improve function or your ability to perform something that is now quite difficult. If it's just trying to reach up into a kitchen shelf, then that's our goal, is to try to obtain the mobility, provide the strength, or just get back to your everyday activities that are pretty difficult. We're going to use it to avoid surgery, like Dr. Slattery mentioned. There's most any common thing or problem that he mentioned. Physical therapy is going to be one of the main interventions to avoid surgery. A lot of times we're going to see people following surgery as well. There's going to be a set of protocols and the way he wants your shoulder to heal, and the physical therapy are going to have enough skill and knowledge usually and experience to know that we need to follow a certain set of guidelines so your shoulder will heal properly and then regain the function and the use that you want it to have. Generally, the first time you're going to come into our office, we're going to just evaluate and see what the problem is. We're going to do an examination and just take your history. We're going to observe how you come into our office. A lot of you will come in possibly kind of with one arm a little forward or slouched. You might be in a sling after surgery. We're going to take a look at your posture. We're going to take a look at even just how you're sitting or standing, because this is going to really probably drive our examination and what we're going to be looking at when we go further into it. We'll take some basic measurements on your active range of motion and strength. We're going to do some comparisons to your other arm that may be working pretty well. So we'll want to see the differences in that regard. checking joint mobility. That means we're probably going to get our hands on you. We're going to see some flexibility or some stiffness issues. Again, we might compare it to the other shoulder just so we have a bit of a comparison. And then the last one down here is biomechanics, or just joint mechanics. There's a few different terms we'll use or say. And in general, that's just taking a look at how the shoulder complex is moving. Like Dr. Slattery mentioned, there's several different bones and joints that make up your whole shoulder complex. And a lot of things can throw that off just a little bit, and that will then make it difficult for you to use your arm or to reach overhead. So that's a little bit of a synopsis of what we're going to be probably taking a look at the first day you're in our office. A little bit now into joint biomechanics, or just how your shoulder is going to function. What I tend to look at, especially in the first visit, is just how your shoulder is sitting or how it's resting. You know, I'm going to try to look at your shoulder blade in particular versus the other side. I would say 90% of the patients coming into my office, they're going to have some form of postural changes in their upper back and through their shoulder blade. One side is either going to be kind of sticking out a little bit funny versus the other, or it's just not going to be able to move quite well. And if your shoulder blade isn't moving very well, you're not going to raise your arm over your head very well. So in general, most doctors and physical therapists are thinking about a 2-to-1 relationship in the scapular, humeral, or your shoulder blade humerus motions. So that means if I was able to move or reach my arm overhead to about 180 degrees, you're going to see or have about 90 degrees of rotation outward in your shoulder blade. And however, that's usually not the case if you're coming in for shoulder pain or some form of shoulder injury. So we want to make these comparisons and observations versus the other side. How is that going to affect your daily tasks? Well, I mean, most people are going to complain that without this type of motion, there's going to be breakdown in the shoulder most likely. And as Dr. Slattery mentioned, what caused it? Is it weakness that developed an issue in your shoulder, or is it just stiffness and improper mechanics that then develop? I mean, it can go one way or the other a lot of times. But we're going to really take a look at the mobility and how things should properly function to come up with a better treatment plan as we move forward. A little bit of the role of your shoulder blade, or the scapula we call it. A lot of times this can be overlooked in some therapy offices, or is maybe not discussed all the time when you're possibly seeing your primary provider before you see the orthopedic. But it plays a really important role. It provides some stability for your shoulder in many directions. I mean, if you think about it, your arm and shoulder has a lot of motion. I'm talking about reaching across your body, we're talking about all the way up over your head, and we're talking about way behind your back, all the way in between your shoulder blades if you had some pretty good flexibility. So there is so much motion in your shoulder and arm that your shoulder blade has to provide a lot of stability in different directions. And as he mentioned with the rotator cuff, every single rotator cuff muscle you have begins and starts in your shoulder blade as it moves towards out to the head of the humerus here. So things have to work together really smoothly, or you start to notice you just aren't able to move and reach and use your arm quite as well. So as he mentioned, if the supraspinatus, or one of these rotator cuff muscles, tends to break down or has a partial tear or is just really inflamed, it's like driving your 4-cylinder car with 3 cylinders. It's not going to run very smooth, and you're going to start to develop possibly some compensations and some poor motions. As it says below, just, you know, when things are working smoothly, you'll have smooth coordinated motion. If something's breaking down, you're going to notice uncoordinated or difficult motions. You know, you can think about if you're having trouble reaching with your arm, your uncoordinated or compensated motions is probably going to look like this a lot more than just something a little smoother like that. Not that I have a perfect shoulder or anything. The basic motions of your shoulder blade is shrugging upward, pushing or depressing your shoulders down like the picture shows. It's a little bit small. Pinching or retracting your shoulder blades back. A lot of us don't have enough of that. You'll see most people coming into my office, they're going to be protracted or their shoulders are forward. A lot of it is also related to your spine problem possibly. You're going to have really good upper traps possibly, so you can't get your shoulders back and downward in a better position. But as you reach overhead, the shoulder blades will rotate outward, and of course when you bring your arms back down, or if you reach behind your back, your shoulder blades will rotate inward a little bit. So those are the main motions through your shoulder. This video here, hopefully that plays, was supposed to be about some of the visual observations that us in the physical therapy realm will take a look at when you come into our office. I'm not sure if it's going to play though, so. Where's my IT person? Well, it worked on my computer, of course.
I don't know how to do that.
Well, we might be skipping that. Well, anyways, the video was basically showing a young lady who had some lack of motion reaching overhead. And it was just basically giving you a visual, a little bit what we would look at, mostly through the back portion of her upper back and shoulders. And it just talked about how she had, she exercised a lot. She did a lot of upper trap work and a lot of shoulder presses with weights. And she developed very nice upper trapezius or shoulder muscles. Unfortunately, this created a little bit of an imbalance where she didn't have a lot of lower trapezius or back muscles. So her shoulder blade then was not able to quite move smoothly or coordinated together with the rest of her shoulder and arm, so she was limited in some mobility on one side versus the other. But it was very difficult to see or observe unless you were kind of looking at the back portion of her. But anyways, it was just an example of what we may look at if you come into our office. Unfortunately, that video doesn't work. So one of the main goals we will try to do is improve your range of motion, obviously. A lot of your personal goals will be trying to reach into a particular cabinet or up a shelf or just do some gardening. So one way we try to improve motion is through some manual joint techniques. We'll get our hands on your shoulder or your shoulder blade. We'll try to improve some flexibility and some nutrition through the area. Just try to see if we can get things loosened up before we move into some other exercises. A lot of things that we'll do in our office, we're going to try to instruct you for a home program. This home program is going to be pretty critical because if we're only seeing you once or twice a week, you're going to need to do a little bit of homework on your end to have some really good outcomes and good results, especially if something is going to be prolonged and maybe under a protocol following surgery. It's going to be pretty instrumental in reaching your goals. Some of the guidelines, as I mentioned, will be done by a protocol following your surgery. Others are just going to be based on what is needed if you're trying to avoid surgery. Moving into some shoulder stretches could be as basic as just using some pulleys or a rope overhead. This way you can kind of assist your arm with your good arm to start getting some flexibility going. Try to kind of loosen things up in the structures and muscles around your shoulder joint. Just try to progress it in a very gentle, easy way. And then as it kind of loosens up and begins to maybe get a little less sore, we're going to do things a little more actively and progress into some strengthening type exercises. So strengthening exercises are pretty important. We're going to try to at least promote any of the muscles around the area to function properly. Also, with a lot of arthritis out there, it's kind of like a bad knee joint. If the doctor says you could use some strengthening to help support the knee joint, well, the same thing could be applied for your shoulder or shoulder blade or your upper back area. I spend at least half my time probably working in posture and upper back and shoulder blade area, because that is usually what is the weakened part of someone's shoulder or just shoulder complex. In a day and age where we have a lot of sitting type jobs as well, where people are hunched over and slouched, there tends to be a lot of overstretched muscles and weakened areas throughout someone's upper back and shoulder blade area. So we're going to try to improve a lot of strength throughout the upper back as well as the shoulder and arm. This would probably be added to the home program as long as it ends up being tolerated and progress to a certain point where you have some good toleration to that. Plus, it's going to be used to help prevent any further breakdown or further injury you may have in your shoulder. So these are just a few pictures of just some sample exercises that you may do or have seen before. We'll use some weights, some dumbbells, sometimes we'll use some TheraBands or some pulley weights. If you want to stop by next door to my office after the questions at the end here, you can take a look around a little bit. Some of the rotator cuff exercises we'll do will be very specific, especially if your problem is related to rotator cuff. As Dr. Slattery mentioned, there's some rotation that occurs if you want to specifically break down what some of the rotator cuff muscles do. So we may get very specific with some of our exercises if we find that's an area of weakness or an area that needs to be worked on. Some continued exercises that you may see, especially for the upper back. Some rowing exercises are never usually a bad thing to do to help maintain good posture and position of your shoulder blade. A little bit of stretching behind your back is usually a very common thing that's limited in a lot of people. So we may slowly progress you into that type of a stretch. We'll do some pain relief as well. We're not all about trying to torture and inflict pain. Some of the things we're going to do will probably cause some discomfort or pain, but hopefully we see gain, as in better mobility, flexibility, better strength. But we'll try to use some heat. We'll use some ice to try to decrease inflammation. We'll use some electrical stimulation modalities that, tend to maybe improve a little bit of blood flow or decrease some swelling. Just, some people feel that it helps with their pain or soreness, and if that's what makes them feel better, I'm all for it. So there's just some of the things we may use if we feel necessary or you want to have a little less soreness. So mainly our results in the course of time that you're in our office is, of course, to reduce your pain. And that then hopefully improves your motion, your mobility, your flexibility, and your strength, obviously, in your shoulder. Our main goal is to try to return to whatever prior level you had, or whatever goal or whatever problem you had that you want to get back to. A home program is probably going to be necessary for you to continue with for at least a certain amount of time. It just depends on maybe how long you were battling this injury or this problem, and maybe if it's something that was a very long-term problem, you may have to touch on it for quite a period of time just to kind of maintain the progress we made while you were in the office. There's a lot more things to dive into with the shoulder. These are just some real basic stuff that we look at if you come into our office and what we may be working toward. I don't really have anything further to add at this time because I know everyone's going to have some kind of particular questions. So I don't know if Dr. Slattery is right here if you have further questions for him, but if you have a particular physical therapy question for now, I'll go ahead and answer it. Awesome. Everybody got exactly what I wanted to hear. That's great. That makes my job so easy. All right. Well, if anyone has questions later, I'll be around for a little bit. And, here's my information. Usually I can be reached by email much quicker and faster. I have business cards outside too if you want to take one, if you have questions later or something like that. But thanks for coming out, and I bet if Dr. Slattery wants further answer any of your questions. We'll be hanging out here for a little bit, but thanks for coming.